divide ourselves into pediatric spine deformity surgeons and adult spine deformity surgeons. But for those of us who treat both populations, we can really appreciate a unique perspective on pediatric deformity, including which cases we wish we could have gotten to as children, which cases are particularly bad actors if we let them progress into adulthood, and what cases might otherwise be left alone, that seem like a significant pediatric deformity, but maybe we can watch those and just observe those into adulthood. We'll highlight some important themes and considerations and pearls that'll kind of bring some new perspectives to how we look at pediatric deformity cases. This intersection between pediatric deformity and adult deformity is really the focus of our pediatric and adult spine meeting that we do yearly in Hawaii. So for those of you who find this particularly stimulating, consider yourself cordially invited to join us next August 3rd through 6th in Honolulu. This was some photos from our last year's course. So our goals today are to recognize particularly bad actors for the pediatric spine patient, pediatric deformities that may be problematic in adulthood, leverage what we know about adult sagittal and coronal alignment to guide our treatment for the pediatric deformity patient, and consider the cost-benefit trade-off between the straight and stiff spine or fused spine and the flexible spine with some residual deformity. The difference in presentation between our adult patients and our pediatric patients can be stark. On the left, these are both patients with idiopathic scoliosis, but on the left, we have a 12-year-old with no pain, doesn't know why she needs surgery, and really doesn't want to be in the hospital. On the right, we have a 32-year-old woman with a much less severe deformity, but with severe pain and severe disability. So we really are seeing patients at a different, a markedly different point in presentation. With this severe idiopathic deformity, this case sort of highlights a couple important themes in treating pediatric deformities. Generally, we're treating flexible deformities. And so this patient, her deformity is amenable to traction. We can reduce the significance and severity of her deformity to a very treatable magnitude over a course of 4 weeks and get a reasonable clinical result without much of a risk to the patient. So much different than what we would need to do if this patient had progressed into adulthood, where traction may or may not work and we'd be dealing with a much more stiff deformity. The key differences here are that the pediatric patient, although this deformities can be severe, they're generally flexible. Typically, they present with very little pain. Their compensatory mechanisms are very well tolerated, and this is kind of a key theme and a key thing that I want everybody to pay attention to as we talk about our goals for pediatric correction. And I think the fact that pediatric compensatory mechanisms are so well tolerated, we often, I think, have a bit of a maybe overly optimistic view of what we've achieved in the pediatric deformity correction, particularly when we think about the sagittal plane. Generally, pediatric patients have good bone unless they're syndromic or malnourished, and they have favorable biology for healing and favorable biomechanics, particularly when it comes to disc degeneration. So we don't have the same mechanical environment that we're trying to achieve a fusion in as we do in the adult. On the adult side, the deformities tend to be more stiff. The sagittal plane progressively worsens as discs degenerate. Patients generally present with pain, and we need to address spinal stenosis, either current or impending, with our correction. The compensatory mechanisms are much less well tolerated, which is often the source of disability and the reason patients are presenting to us with spinal deformities. And then depending on age and other comorbidities, their ability to heal a fusion is variable. And again, the biomechanics of disc degeneration come into play because as we induce lordosis over degenerative discs, we run into the problems of pseudoarthrosis and loss of correction that we just don't see in pediatric populations. So the sagittal plane considerations first. So in idiopathic scoliosis, the vast majority of patients have hypokyphosis. So we're generally trying to induce kyphosis, which is sort of a counterintuitive idea for the spine surgeon, but trying to increase kyphosis in the thoracic spine, which is arguably, I would say, for routine scoliosis, one of the most difficult things to do. And then in lumbar scoliosis, it's important to match the position we fuse the lumbar spine to pelvic incidence and really think about the shape of the lumbar spine in context of the spinal pelvic parameters. Lumbosacral gave us this concept of the cone of economy, which generally speaking is the idea that there's less disability when the head and the torso are balanced over the feet. And as we deviate out of that cone of economy, pain and disability ensue. And so our compensatory mechanisms are trying to bring us back into that cone of economy, and the spinal deformity is trying to throw us out of that cone of economy in broad terms. Although the spinal pelvic parameters and pelvic incidence are not well worked out in terms of how we should apply them to pediatric deformity, there's no doubt that we can all agree that a patient with a pelvic incidence of 30 needs a different fused position of their spine than a patient with a pelvic incidence of 70. And so, I think the concept is clear. We just need more research to tell us exactly how to apply those principles for the pediatric patient. This brings us to our first case. This is a 13-year-old with adolescent idiopathic scoliosis. She's RISR 3 and presents with a Lenke 1B minus. She's significant thoracic hypokyphosis, as you can see here on the right. And as we often see in hypokyphotic scoliosis, there's cervical kyphosis, which is her attempt to bring the center of gravity of her head roughly over her hip center. And so that's just to my eye, when I see that, that's a secondary sign that this patient doesn't have nearly the thoracic kyphosis that she ought to have given her pelvic incidence and lumbar lordosis. And so part of what we try to achieve with her correction is correcting the coronal plane. She has a 1B curve, so we're trying to more or less get the LIV parallel to the sacrum, and then trying our hardest to induce some kyphosis. And, she certainly didn't end up with a lot of kyphosis, but I think it's an improvement upon what she had, and enough that we actually see she's now reversed her cervical kyphosis and has a more normal cervical alignment. And hard to say what long-term clinical benefit that will have, but again, we're just trying to give her as normal of a sagittal alignment entering adulthood as we can. What are our tools for correcting the sagittal alignment in pediatrics? We have rod bending. So in thoracic scoliosis, my strategy is to use a stiff rod, particularly on the thoracic concavity of the curve. We hyperkyphose that rod, so we bend it to have more kyphosis than would be physiologic, anticipating that as we correct the scoliosis towards that left-sided rod, we'll flatten the rod out and hopefully end up with, close to physiologic kyphosis. We expose type 1 osteotomies are helpful, particularly for the coronal correction, but we really are limited in how much thoracic kyphosis can be induced when we only use type 1 osteotomies. And for those of you not familiar with that terminology, type 1 osteotomies are inferior articular process facetectomies, so partial facetectomies. The reason we're limited in inducing kyphosis is because the ligamentum flavum and the ventral joint capsule are dorsal ligamentous structures which limit the ability of the dorsal column to lengthen. And so the dorsal column will need to lengthen in order to induce kyphosis. So that's where the type 2 osteotomies, or the Smith-Peterson or Ponte osteotomies, all sort of the same concept, in that we're removing part of the lamina, the interlaminar ligament or ligamentum flavum, and either the superior facet or the joint capsule, to allow more instability of the dorsal column, and in particular, lengthening of the dorsal column to induce kyphosis. So this helps both with derotation as well as induction of kyphosis. And in my mind is really indispensable for achieving our sagittal plane goals in hypokyphotic scoliosis. And a reduction, rather than a CD derotation maneuver, I use a bulk derotation maneuver to try to bring the spine up to that hyperkyphosed rod, and using derotators from the opposite side, try to lock in as much kyphosis as we can get. Moving on to some of our bad actors. So the bad actors are the deformities that are particularly or predictably surgical in adulthood, those that are already causing disability in the adolescent. So what comes to mind there is isthmic or dysplastic spondylolisthesis, those that tend to be progressive, and that's where our congenital deformities and some of our idiopathic deformities come in, and then those that tend to be associated with pain in the adult, and that's sort of your Schurman's kyphosis that's been progressive in the adolescent. And on that list, we have, again, high-grade spondylolisthesis, lumbar hemivertebra with a significant cob, congenital kyphosis, Schurman's kyphosis, and the lanky 1AR curve, which, as we know, has a very high risk for distal decompensation, both preoperatively and postoperatively. And then there are some deformities that some of us would feel, particularly some of us who see a lot of adult patients, would feel are sort of observable. And I would argue that a low magnitude lanky 1A curve, so not a lot of induction of lumbar deformity, and a particular curve that's been stable, is something that I would just observe and leave alone, and see if it and can be treated very easily as an adult without much additional morbidity. This is an example of a severe Schurman's, a 30-year-old who presents with more than 100 degrees of kyphosis and thoracic myelopathy. He had been offered surgery, and his parents had declined as a teenager. In this case, he's gone on to autofuse the apex of his deformity posteriorly from T6 to T12, and anteriorly across the apex from 10 to 12. And interestingly, had developed ossified ligamentum flavum and severe thoracic stenosis at the apex. So his surgery, which would have been a nice kind of slam dunk case as a 14-year-old, has become a very high risk case, necessitating a 2-level VCR and thoracic decompression. So this was his decompression and VCR, and a reasonable result. But again, I would have much rather treated this as a 14-year-old. This is his clinical photos before and after. The 1AR curve we'll talk about a little bit more, but this has been identified as a curve that's high risk for distal junctional or distal adding on. And so selection of levels is a particularly important issue with this curve type. Another patient with hypokyphosis, and despite our best attempts at inducing some kyphosis, we really were quite limited in what we could achieve there. But you know, the teaching point here, or the important point with these 1AR curves, is identifying the proper LIV so that you mitigate the distal adding on. And then finally, the theme I wanted to touch on before moving to some of our case presentations is the the straight and stiff versus the flexible and curved spine. And so this comes into play when we're looking at our lanky 1Cs and those curves with significant thoracolumbar or lumbar curves, so subtype C curves. This is a 13-year-old, wrists are 5, skeleton mature, with a lanky 1C minus. Quick note for the trainees on the call: do your best to do as much pre-op planning as you can. My rule that I kind of urge our residents and fellows is for every 6 hours or so that you're in the operating room, you should do at least an hour and a half of case planning to make sure that you are prepared to know everything you possibly can about the deformity you're treating. So in this case, there are some positive predictors of being able to achieve a selective thoracic fusion, and these were published by Lanky and colleagues. Her AVT, or apical vertebral translation ratio, was 1.4, so above 1.2 gives us a favorable chance of achieving a selective thoracic fusion, and AVR was above 1.2 as well. And so this is pre-op and immediate post-op, and it's kind of a cringeworthy film initially, and some improvement by 6 weeks. And at this point, I think, we're in the probably high 20s for that lumbar curve, and hoping that she holds on. 2 months, she's seems to be holding on and not progressing the lumbar spine. And then finally at 2 years. So, this raises questions. This is not a beautiful X-ray. It is, she has a residual 27-degree lumbar curve, but as a dancer and as an active person, I would argue that this is more functional and favorable, if this was my child, than a fusion that goes down to L4 and leaves her straight but stiff. So, thought for discussion. Just a reminder, we do have a meeting in Las Vegas coming up first week of November. So for those of you interested in complex spine, please join us in November in Las Vegas. Thank you very much.
All right, for my next.
Hey, Lionel, terrific overview. And let's go ahead. I think you set up each of the fellows with a couple of cases. So Ali, why don't you go first?
Yes, sir.
So this is, again, Ali Mazaid is one of our fellows. He actually trained and was in practice in Los Angeles. Subsequently, he spent some time in Egypt where his father is one of the senior surgeons in Cairo. And he's now doing some advanced training in our program and doing a terrific job. And Ali's going to present a case of a early onset scoliosis. So go ahead, Ali, take over.
Okay, can you see the screen? Okay. Well, thanks for having me. Let me just start by following to Dr. Metz's presentation. I believe early onset scoliosis is one of those deformities that need to be addressed earlier and taken care of, because obviously they progress pretty bad. By definition, early onset scoliosis is the type of spinal deformity that usually starts before the age of 5 in some literature, below 3 years is termed infantile, and there are different reasons for it. Could be true idiopathic early onset or other syndromic or some congenital etiology as well. The untreated form that are progressive can really affect the patient's mortality rate up to 18% in some studies. And that is usually due to lung insufficiency following the excessive spinal deformity. Also, on the other hand, early treatment by extensive fusion would lead to thoracic insufficiency in those patients and reduced vital capacity. So they need to be treated differently than definitive treatment early on. And as we know that thoracic growth is mostly rapid in the first 5 years of life, then it kind of declines and then starts to accelerate again following the growth, along with the growth spurt. So the management options in those patients are, classically they've been repeated lengthening procedures or multiple procedures every 6 months or so with growing rod constructs, and but the complication rate with those has been pretty high, up to 24% addition for the complications with each episode of growing the rods surgically, or lengthening, I should say. And the later you start with this kind of instrumentation as the initial implantation, the less the risk of overall having complications in those patients. So in some studies, they think if the curve is manageable, you could wait up till the age of 7 years to kind of decrease the potential for risks. Now, fortunately, there's other methods of treating those patients with magnetic rods, and this patient is one of those patients that have been. So we have an 8-year-old patient with early onset scoliosis that had failed trial of bracing for about a year due to non-compliance. He had other congenital issues like aortic congenital diaphragmatic hernia, and had a number of surgeries prior to presentation as a younger child. On exam, he was well-nourished, neuromuscular intact. He had the normal gait on exam. He had some asymmetry in his waist creases, but not much in the shoulder height. Exam was pretty normal with good motor power overall. So imaging that were taken at the time, it showed a thoracic and lumbar curve, 80 degrees of thoracolumbar and about 70 degrees of thoracic. MRI did not show any neural axis problem. So I just put those slides here to show that initial presentation can really vary over time. So initially, the patient presented. I mean, this is the earliest I could get, but probably he was diagnosed earlier than this. But you could see that started with a 44-degree curve, 50-degree curve. I think at that point he was recommended some form of bracing, but they just were not compliant, and the follow-up was not the best. Over time, over a period of 2 years, it was still manageable, but then at age 8 years, you could see that it jumped to 70 degrees and about 79 degrees there. So at that point, the thought was to intervene. And the goals of treatment generally in those patients is to control the progression of the curve while allowing the pulmonary development. So it's kind of a balance between both. So I believe in this particular patient, he had a halo traction application for about 2 weeks in hospital. And then he was planned for a magic rod surgery. So I didn't start with that. So as you can see here, I believe this slide shows kind of the plan intra-op, how the process of doing the surgery was. Initially, there was a temporary rod on one side to kind of distract on one side, while the other magnetic rod was put in, and vice versa, like switching between both sides. And the configuration that was done is like 2 rods at the thoracolumbar junction, as opposed to kind of doing that at different areas. So this is the placement of the growing rods on October 2018. You see some correction intra-op compared to the initial or the presentation pre-op to 45 degrees and 32 degrees. And over the time of follow-up, this is in October, about over 33 years, has been growing, and the curve is still controlled at 50 degrees and 35 degrees in the lumbar spine. So this is pre-op. This is what they look like right now, and obviously we need to continue this until he's grown enough to do the definitive surgery. But this obviously buys them less trips to the OR and hopefully less complications overall. And that's it. Thank you.
Maybe I'll start with a question. Lionel, what are your thoughts about when to stop treatment with the growing rod?
I think it's a great question. There's some debate, and I don't know if it was this year or past year at SRS, where there's some debate as to whether or not patients need a formal definitive fusion, meaning a revision surgery to remove the magnetic growing rod and do a definitive posterolateral fusion, or if if we stop expanding the magnetic rod, will the patient autofuse over time? And if the rod doesn't break and they're not having pain, are we in an okay place? So I think that this patient is getting close. I think she's still probably Risser 0 or 1, but she has done most of her vertical growth, and probably in the next year it'd be appropriate to think about a definitive fusion. But again, I don't know. That was going to be my first question to the audience, actually, is for those of you with experience with either traditional or magic growing rods, are you going back to do definitive fusion, or are you letting the spine autofuse on its own?
Maybe we put Dave Skaggs on a line. I see Dave's there.
Hey, Sid, how are you?
Great to see you.
Hey, Dave.
The pediatric spine study group finds that a little bit over 2/3 of these kids end up getting fused. With traditional growing rods, of course, you could just leave them in, and if they auto fuse and they're fine, why do another surgery? One of the things that might be different with magnetic growing rods is the FDA has only approved them to be in for 2 years. They're known to kind of have leakage of metal and stuff like that. Nobody really knows what it means or not. Then the other thing that happens in a kid if the triradiate cartilage are still open, or if they're still growing, and there is some early posterior fusion, then crankshaft can continue. So that might be an indication to go in there. As we all know, when you go in there after there's growing rods for a few years and there's some level of stiffness or autofusion, you have to do a lot of osteotomies, and you kind of never really derotate them as well. But it looks like what you did so far is wonderful. And as long as the expectations are tempered, it's probably never going to be a full correction. But my vote would be not to leave in magic rods forever, because it's against FDA recommendations, and we just don't know the long-term kind of metal magnetic leakage stuff.
Got it. Yeah, that's great.
It's good to see you guys again outside Hawaii.
Good to see you too. All right. So
I had a quick question before.
Yeah.
So in cases where we don't do magic rod, like the regular growing rod, and again, is there a cutoff where you say, okay, let's do it, like in terms of years wise, or you just go by the growth spurt? And like, if let's say they're 2 years post-monarchal, or 1 year, or just starting their growth spurt, how do you kind of gauge when to intervene for the definitive treatment? Because obviously the longer we wait, the more repetitions or revisions or the potential complications leaving the rod in. So when do you say, okay, well, let's just cut it a little short instead of doing that last lengthening? Because the spine, at some point, the law of diminishing return, you could feel that it's not really extending. But let's say they're like 10.5 years or 11 years, and you're not really getting much from the standard growing rod. Do you say, okay, let's just fuse it at that point? Or?
Yeah, so Ali, that's a great question. For those of the people on the call that don't know what you're talking about, the law of diminishing returns is when you have growing rods in, every time you go in to lengthen them, not only do you lengthen less, but it takes more force to lengthen less. So at some point, they don't work anymore. And the bottom line practically is you go to the definitive fusion when the mom tells you to, because once they're sold in the idea of growing, they're almost never going to accept not growing and not lengthening. I generally try to talk them into the final fusion around age 10 or so, because every time you go in for a surgical lengthening, especially, you increase the risk of complications, whether it's infection or whatnot, by 25%. So the quicker you can get the growing stuff out, the final stuff in, I think the better for the patient. Hey, Ali, the other thing you pointed out nicely is you put the very straight magnetic portion at the thoracolumbar junction, which is straight. People have made mistakes before by putting it up high, and then it becomes a PJK machine. So you did that nicely and explained it nicely.
Thank you, sir.
That is another challenge with growing rods is the patients who are kyphotic. But let's transition now, and we've got our next fellow, Ravi Srinivas. And Ravi had done a fellowship in spine surgery with a group down in Greg Mundis and a group down in San Diego, and he's now doing some more advanced work with us at UCSF. We're happy to have Ravi as part of our team. And Ravi's got another case of idiopathic scoliosis. So Ravi, why don't you take over?
So Sig, you said this is idiopathic scoliosis?
This is actually a congenital case.
I thought Sig was setting us up.
Yeah, I got to admit, I'm not sure which one Ravi's showing here. So I'm introducing Ravi. Ravi will introduce the case.
Sorry about that. Yeah. So anyway, so this is going to be a congenital kyphosis patient. So just briefly, we know congenital kyphosis is usually progressive without surgical intervention. Current treatment recommendations include a posterior arthrodesis for deformities that are less than 50 to 60 degrees, and anterior releases and decompression, anterior fusion with posterior instrumented fusion for larger deformities and for cord compression. So this is our patient AB. When he came to San Francisco, he's 11 years old. I believe he'd previously been treated at another institution, was being treated conservatively without surgical recommendations. So San Francisco, he comes to Dr. Metz's office. He's 11 years old. He has a history of a ventricular septal defect that's status post repair. He's had to have a nephrectomy. And he has a complex congenital kyphoscoliosis of his thoracic spine, which we'll show you in a second. He is neuro intact. He does have asymmetric scapula. The left is higher than the right. On Adams Ford bend test, the left thoracic spine is higher than the right. His shoulders sit symmetric, as do his waist and iliac crest. So this is when he came in at 11. He has this 61-degree kyphosis, T9 to T11, and the 34-degree coronal curve. Discussions about surgical treatment were starting to be had at this point. We see him in 2017 and progression of his curve significantly, where his curve is now 105 degrees, his kyphosis. His coronal curve is also increasing. And also his T9, he has a hemivertebrae. T10, he has severe anterior wedging. T11, he has a asymmetric butterfly vertebrae without a right-sided pedicle. Then we come and turn to his fixed, then we see his flexion extension, or rather his prone supine bolster films that show a rigid deformity with minimal flexibility. He also had MRIs done. He has draping of his spinal cord over the gibbous of the deformity. And then we'll show you in a minute that this is the CT scan was used to make a 3D model, which we'll show you in a few slides. So here's clinic pictures of him at 13 years old. This is after the deformity had progressed to the 105 degrees. Then we have, again, here's a close-up of the two, and this is the plan for the surgery. You're doing a T6 to L3 posterior fusion with the VCRs in the front, T9, T10. with Dr. Metz and Dr. Bervin. The 3D recons, the 3D printed model that was made to prepare for surgery, and plan the pedicle screw projections and the hardware. And then so the patient was taken for surgery in detail. He had his T9 hemivertebra resected. He had T10 VCR. The left T10 nerve root was ligated to gain access. An anterior interbody titanium cage was used. He had laminectomies done T8 to T12. And that aided in the correction at L1 to L3. Schwab 2 osteotomies were performed. And then again, the posterior fusion using pedicle screws T6 to L3, 5.5 millimeter cobalt chrome rods, and just the correction maneuvers, sagittal compression in situ bending via temporary rod, and then coronal compression on the convexity, distraction on the concavity. So here are his films immediately pre and post-op, and then his clinical images. And then I just want to show this is immediately post-op, standing films. And then he started developing this reciprocal, or rather this junctional kyphosis, but he's not having any pain and neurologically intact. 2 years later, the kyphosis is not progressing. He's doing well. He's in school with no complaints. So, key points are, early surgical intervention is best in congenital kyphosis because it will progress. If the deformity is under 60 degrees and there's no neurological deficits, then posterior fusion alone is possible. Gradual correction with growth can occur after the posterior in situ fusion, but that's only in younger children. And immediate correction of a deformity with a hemivertebra excision is safe in younger children and can be attempted, even though he was done a little bit later in age. That's pretty much it.
Thanks, Ravi. Yeah, I think you hit the key points. I think the idea that getting to this earlier would have been nice. I think we could have potentially done less than what we did. Although this isn't your typical kind of hemivertebra. It was a more complex congenital deformity, but it's always, I think once you know, this is a good example of a bad actor. I think once you know that it's progressive, you want to get to it as early as you can because it's safer and potentially you can fuse fewer levels. But I think particularly vexing is following these patients for a few years and seeing I don't know if you'd call it reciprocal kyphosis or proximal junctional kyphosis without failure, but this seemingly unstoppable force that wants to bring his head center of gravity to where it was before the operation. So would love to know if anybody's figured out how to mitigate this, maybe going longer. And I think some might advocate for going a bit longer proximally, but bracing longer, I'm not sure what the answer is, but I think something that we just unfortunately deal with these kyphosis cases.
One of the things you did really nice here is derotation. It's not easy to get it as derotated as you did.
Thank you. And I think one important teaching point for the residents and the Kohler fellows going into practice next year is, this case I did with Sig, Dr. Bervin and I think this is the type of case where you really want to have kind of the best possible team you can have going forward. So 2-surgeon technique and I think that's been shown in adults as well as pediatrics to make complex surgery safer.
I said it's nothing more lonely than being by yourself when the motors drop out. And these are high risk cases. These cases with
Yeah.
a high deformity angular ratio, the
Yeah.
congenital kyphosis cases. Recognizing this, as Robbie suggested, that the preoperative natural history of this is poor. So recognizing the type 1 cases and then treating them early and finding a friend. I think that's the secret to having some longevity perhaps in this field is not being by yourself.
Yeah, when the trainees are taking tests, if you have progressive congenital kyphosis, the answer is always operate early. You know, you could often do a much smaller surgery early than later.
Yeah.
And that's part of the underlying theme that Lionel put together here is things that we ought to take care of during childhood. Plenty of things we wait into adulthood, but these are cases to treat early. So our next speaker is going to be Amir Gadazi, and Amir joined us after doing his residency in UC Davis. And Amir, go ahead and take over and show us this congenital case.
Thanks, Dr. Bervin. So today I'm going to be presenting a case on one of the bad actors that Dr. Metz was discussing, and that's a lumbosacral hemivertebra. This is a 20-year-old male with history of Klippel-Feil syndrome and multiple congenital anomalies, including an L5 hemivertebra, who presented to our clinic with progressive back pain and truncal shift in the setting of a congenital scoliosis. At the age of 8, he was incidentally diagnosed with congenital levoscoliosis with a L5 lumbosacral hemivertebra. And he was followed radiographically at that time because he was asymptomatic. At the age of 12, we found some radiographic progression of the scoliosis, but he was relatively asymptomatic and was treated with bracing. However, he was lost to follow-up at that time and then presented to our clinic at the age of 19 with severe progression of the levoscoliosis with back pain and truncal shift. At this time, the proximal thoracic curve that was present was 39 degrees with a main thoracolumbar curve 64 degrees and a lumbar fractional curve of 37 degrees. Thoracic kyphosis was 25 degrees with a lumbar lordosis of 44 and a PI of 50. On lateral bending films, he had a relatively fixed proximal thoracic curve, secondary to actually his Klippel-Feil. That was where he also had some congenital autofusion at the upper thoracic region. In the thoracolumbar curve, he actually had reduction from 64 degrees to 30 degrees, which was relatively flexible. And then the lumbar fractional curve reduced from 37 degrees to 29 degrees and was relatively rigid. We had CTs of the lumbar region, which demonstrated the hemivertebra that also was autofused at the level of L4-5 facet. So we considered different surgical approaches, being fusion in situ, posterior only approach with type 1 or type 2 Schwab osteotomies, a 3-column osteotomy and posterior approach. And
maybe,
then
sorry to interrupt, maybe Amir, before getting to the punchline, we can poll the audience to see, you know, how people would address this one.
Sounds good.
Can you show us the x-ray again if you want our opinion?
Yeah, go back a slide and show us the staining films.
I mean, I think you're probably going to have to do a resection of the congenital curve. I'm not sure I'd call that a fractional curve, and probably a standard posterior fusion on the way up.
I tell you, man, this one I really want to see where the flexibility is, because the structural part of this, I think, is from that L4 to S1. And when you look at the bending on this, I can't quite see the numbers there, but there is some flexibility in that thoracolumbar area. And I might think about going real short on this. I might think about seeing what happens when we level L4. So do the hemivertebral excision, level L4. Again, at this point, I think he was 19 years old. Is that right?
Yeah, 19 years old.
But
So
I might think about seeing what happens if we go L4 to S1. You know, it's interesting because in the pediatric world, we're so used to dealing with things above L4, and I think in the adult world it's almost the opposite. And this is where I think learning lessons from one another. I might try and do something short at the lumbar sacral area and see if I could leave him reasonably well balanced.
Yeah. Sorry, go ahead.
One of the things I do for decision making for the long thoracolumbar curve is there a lot of rotation. I'm going to guess there's a lot of rotation because if you go back when the kid was 12 years old, there was a lot of rotation. And that's at the point where I was worried that, hey, you know, if that's already starting to rotate, this is going to become its curve all by itself. And it's not just a pure coronal reaction to the congenital hemivertebrae.
Yeah, that's a terrific point. That's kind of Ruth Maida's basis as well, right? Looking at the vertebral angle as a metric of that, and I agree. This probably had a poor prognosis even at an earlier age.
Yeah, I agree with everything. At some point, this compensatory curve really started as a compensatory thoracolumbar curve turned structural, and we can see from the bending, if you go back to the bending there, that although it's partially flexible, it's still, I would say, structural at this point. One thing to just consider is really the only flexible part of his spine was from about, somewhere in that mid-thoracic region down to L4 or so. Or maybe T8 to L4. Above that, so the upper thoracic spine is all kind of a congenital jumble. You can see the rib anomalies and whatnot, and then he has congenital fusions throughout his cervical spine as well. So one consideration here was, in terms of which curve to address and how long of a fusion to perform, was that we wanted to leave him with some mobile segments in his spine. And so that was kind of what Dr. Bourbon said about going short. I think Dr. Skaggs said as well was my idea as well. All right,
All right.
Yep.
There are no other comments. So we did as Dr. Bourbon suggested, with a two-stage approach. We went ahead with an L3 to S1 A lift, followed by a posterior fusion L3 to pelvis and decompression.
A lift. So I figured that would throw everybody off.
Yeah. Why the A lift?
So the A lift, a couple of reasons. One is that I thought that the morbidity of a 3-level A lift for the limited goal of basically trying to level L3 to sort of a coronal angle that would balance what he could spontaneously correct on his thoracolumbar curve. So my goal wasn't to get L3 or L4 parallel to the ground because of the stiffness of his thoracolumbar curve would have kicked him way over to his right side. So the idea is doing something that's easy to recover from, low morbidity, low neurologic deficit, and that I knew would fuse. And so this is sort of what I came up with. With that said, for the residents and the fellows, an A-lift, 3-level A-lift on a 19-year-old has, risks of retrograde ejaculation and other risks that you need to be aware of, but fortunately he did fine. So undercorrected, but flexible.
That's a nice balancing of structural curves there. And I'd like to see the follow up on that. When John Hall taught me how to do this, it would be a simultaneous front and back. I think, as you know, Lionel, we've done some of these all from the back as well. But,
yeah.
This is a nice example of balancing two structural curves.
Yeah.
What do you think, David?
If the patient looks good, then you've won.
Yeah,
Hopefully,
I think
without 30-year follow-up.
Right. Yeah, I think we have maybe 2 years on him. He's happy. And again, I think the fact that he, number one, he fused, and number two, he has maintain some motion of that thoracolumbar region. He's happy with that. I don't think there's a way to, without, again, that concept of the trade-off between a stiff spine that's straight and a flexible spine that's curved. I think, particularly with clipophile and the upper thoracic autofusions, this was a reasonable strategy.
So when you said, so did you do the A-lifts in part because you were worried a 19-year-old would not fuse?
No, I thought he would likely fuse with an osteotomy. I just thought that this was, lower morbidity, basically, is he went home post-op day 4 and,
Lower morbidity than what? I'm sorry, I don't understand.
Than a VCR or than a.
Oh, okay. So you didn't take out the hemivertebrae.
Did not take out the hemivertebrae.
Got it. That's what I
missed.
Sorry. Thank you.
Sorry about that. Yeah, did not take out the hemivertebrae, just A-lifts. And you can see kind of on his AP, the hemivertebra, it was a pretty large one. So it'd have been, I think, difficult to cancellate that and get it to settle just right to balance his curves. So I thought this was a bit more predictable than that.
So then let me ask you, do you think you could have done this all from the back without the A-lifts? I guess what I don't understand is, what did the A-lift add?
So the A-lift, the way the technique I use for the A-lifts these are hyperlordotic cages that I actually put in at an angle across the disc space. So you put in from left to right so that the lordosis of the implant actually works as a coronal wedge. So you kind of kick you kick the spine over by introducing these at an angle. So that was sort of.
So you felt that you could get more correction with A-lifts and you could have posteriorly alone?
I felt that I could do a more predictable correction. So I could take x-rays as we go, with each of the A-lifts and see kind of exactly where we were and, have a bit more predictability, less blood loss and less morbidity by doing it this way. But I think, a hemivertebral resection would have been completely reasonable to do as well.
Yeah, we've only got a few minutes left here. And on the topic of anterior surgery, I want to introduce Nitin Agarwal now. Nitin is another one of our fellows here at UCSF. Nitin did his training at University of Pittsburgh. And on the subject of anterior surgery, I do have to admit that that's probably that hemivertebral resection is one that I typically do more from the back. Nitin's going to show an example of a dysplastic olisthesis case. And oftentimes, the debate of whether to go anteriorly or posterior on these is common. Nitin, let's go straight just to the case. Let's not give the background on this. Just briefly, we're going to talk about the fact that we recognize that dysplastic olisthesis in patients with both lumbar pelvic and global malalignment, that's associated with poor health quality. In my hands, I do a lot of these dysplastic cases from the back. The overall principles are we want to get a circumferential fusion and reduce the slip angle. And this is a case that I did that Nitin will present, where I actually used an anterior approach. And there's a mixture of what I do between posterior versus anterior. Nitin is going to choose a case that I did front and back rather than anterior, rather than posterior only. Go ahead, Nitin.
Good evening, everyone. Thank you for having me. So the patient's a 59-year-old female, history of low back pain, radiculopathy, and an L5 dermatome. All the conservative measures that you would think of were tried without relief. And she's actually known that she's had this problem for a while. So this was actually a developmental dysplastic type condition. I'll show you a zoomed in x-ray in a second, but just to give you an idea of her global alignment, you can see the high-grade spondy at L5S1 and that olisthesis there. And in this x-ray, you can see some features that point to a dysplastic or developmental condition, sacral doming, the high-grade nature. CT scan redemonstrating those findings. And again, the sacral doming there in the image. And here's an axial cut through the area of interest. And it's always interesting when we see radiographic signs, such as like the reverse hamburger sign in the cervical spine. But here, seeing this double vertebrae here from the high-grade spondy was an interesting feature, and the elongated canal on the left. The MRI is striking for the amount of foraminal compression there on the image on the right. So to move things along on the treatment of these and our technique, with such a high-grade spondy, access to disc space oftentimes will require resection of the anterior osteophyte. In the image on the left, you can see an osteotome there taking off that inferior corner, and then to access the disc space. And with serial mobilization, first with the osteotome and then COBS, we are able to slowly start to reduce the spondylolisthesis. Here you're seeing the cage being inserted with fixation just in L5. And so that further reduction can be achieved with posterior reduction of this. So you can see the inserter is still connected to the cage, and there's just fixation in just the L5 body, and on serial imaging, a continued reduction of L5 and S1. Once a reduction has been achieved, the fixation was then performed in the S1 level as well. And primarily, sometimes we'll just do fixation of one, just univertebral fixation if we want to get further correction from the back. But given the high grade nature of this olisthesis and instability, we wanted to do fixation of both L5 and S1 to make sure that this graft did not move. An AP film of this after placement, and on top of that, just to ensure that this was secured in place, anterior fixation plate spanning from L5 to S1.
I'll just point out here how important it is to really mobilize that L5 from the front, and that you can't really rely on banging that cage back, but you got to really mobilize the L5 S1 disc completely, and then this will actually move pretty easily. You can't put too much force on that cage.
Once secured from the front, we proceeded with a posterior approach to ensure fixation and augmentation of the construct spanning from L5 to iliac fixation, sacroiliac fixation. It's important to note here that that following this reduction, we really were able to level the spine out and reduce that olisthesis from L5 to S1. So the reasons why we do this are threefold. One is this reduction maneuver allows us to really maximize and optimize our arthrodesis. Two is we're trying to prevent hardware failure because we're putting things in an optimal condition. And three, what we found is really an improvement in health-related quality of life outcomes. So improving the patient's quality of life through reduction. So I know that's kind of quick there, but trying to meet time. That's our last and final case.
Hey, just a question on the degenerative side of the house. You know, we'll often do grade 2s and occasionally a 3 before sending it over to the other guys. But do you do the sacroiliac fixation for like a grade 2 or 3, or is that just for 4s and 5s?
I'm going to address that. In terms of the iliac fixation, that's got to do with putting strain off the S1 screws. And I think specifically in a patient with really high pelvic incidence, high sacral slope, I think those S1 screws can loosen. So in almost all the high-grade dysplastic cases, I will use pelvic fixation to spare those iliac screws.
Quick question. What biologic do you guys use, Sig?
You know, most of the time for the A lifts, I'll use BMP. For the T lifts, I tend to use local bone with some synthetic. But for the A lifts, I'll use BMP on these.
Quick question: female patients, childbearing years, high-grade spondies, anterior, posterior, and any concerns about blocking the SI joints? Thanks. Great presentations, by the way.
Yeah, great question on that. You know, certainly it was Herbinger who first described the spondyloptosis that can actually cause problems with the spinal canal, and perhaps I'd argue that I would suggest that that's another reason to support reduction, right? Is rather than infusing somebody in situ or transosseous, that's another reason to support reduction rather than to leave somebody with that level of deformity, right?
Question was more towards surgical tactics. So no question, high-grade spondies and women in childbearing years should be reduced if at all possible. But the surgical tactic of fusing the SI joints or blocking them through pelvic screws and anterior versus posterior, that's my question. And anteriorly prominent hardware. So
Yeah, great question. I think she's less prominent with the hardware than she was with the L5 being prominent over S1. But having said that, the role of the the sacroiliac or iliac screws, that's a really good question, Jens. This one was 59, but in a younger woman, I honestly haven't thought much of that, whether or not that might actually restrict the ability of symphysis pubis to expand. So I might suggest maybe iliac screws rather than S2AI screws, but what are your thoughts?
I've had, for some reason, a fair number of female patients in childbearing years with these problems, and I'm very cognizant after talking to my OB-GYN colleagues to put the S1 screws just within the bone and to avoid iliac fixation at all, whatever the technique is, and actually just use Ayler screws in there and leave the SI joints mobile. But I don't know is the honest answer. But beautifully done cases and good discussions. And Dave's great to see you and always fantastic comments. So thank you, UCSF. We'll have to come to a close, but as always, really superb content and educational value. And again, a lot of further thoughts to explore. So many, many thanks.
Thank you.
Thanks,
Same
Sig.
company. It's great to see you.
Nice to see everybody.
Good to see you all.
Bye-bye.
Take care.